Endoscopic ultrasound EUS-guided fine needle biopsy alone versus EUS-guided fine needle aspiration with rapid on-site evaluation in pancreatic lesions, a multicenter randomized trial. Introduction. Endoscopic ultrasound EUS-guided tissue acquisition is the standard of care for the diagnosis of solid pancreatic lesions. Traditionally, sampling is performed through fine needle aspiration, FNA, and the diagnosis is made through cytology. The challenge in solid pancreatic lesions is that they are often fibrotic, with significant necrosis limiting the cellularity of samples obtained via FNA. As such, some tertiary institutions have adopted rapid on-site evaluation of cytopathology, ROSE, to attain a diagnostic yield greater than 90%. ROSE, however, requires considerable expertise, and its availability is limited outside of the most expert centers. Although efforts have been made in the past 2 decades to develop core biopsy needles or cutting needles for histological assessment, it was not until recently, with the advent in 2016 of the fork-tip needle and in 2017 of the Francine tip needle, that truly reliable fine needle biopsy, FNB, devices emerged. Randomized controlled trials, RCTs, have now demonstrated a diagnostic yield of greater than 90%, with both FNB needles and excellent histological yield, which may play an increasingly important role for ancillary molecular analysis and personalized medicine. The important question, however, of whether FNB requires the presence of ROSE remains to be elucidated, and it is unclear whether EUS-FNB alone is comparable to EUS-FNA with ROSE. In this multicenter RCT, Chen et al. Aimed to ascertain the diagnostic performance of EUS-FNB alone versus EUS-FNA plus ROSE in solid pancreatic lesions. To the author's knowledge, although trials have emerged comparing FNB with FNA, this is the first reported multicenter RCT to directly assess the need for ROSE in the era of biopsy needles for solid pancreatic lesions. Methods. A multicenter, non-inferiority, randomized controlled trial involving 7 centers was performed. Solid pancreatic lesions referred for EUS were considered for inclusion. The primary endpoint was diagnostic accuracy. Secondary endpoints included sensitivity and specificity, mean number of needle passes, and cost. Results. 235 patients were randomized. 115 EUS-FNB alone, and 120 EUS-FNA plus ROSE. Overall, 217 patients had malignant histology. The diagnostic accuracy for malignancy of EUS-FNB alone was non-inferior to EUS-FNA plus ROSE at 92.2% and 93.3%, respectively. Diagnostic sensitivity for malignancy was 92.5% for EUS-FNB alone versus 96.5% for EUS-FNA plus ROSE, while specificity was 100% in both. Adequate histological yield was obtained in 87.5% of the EUS-FNB samples. The mean number of needle passes and procedure time favored EUS-FNB alone. EUS-FNB alone cost on average $45 more than EUS-FNA plus ROSE. Conclusions. EUS-FNB alone is non-inferior to EUS-FNA plus ROSE and is associated with fewer needle passes, shorter procedure time, and excellent histological yield at comparable cost.